Welcome back. This is Dr. Reinoso again. We'll now address the issue of sleep deprivation. Let's start with the first slide. More commonly, sleep deprivation is used to imply sleep restriction that is behaviorally induced, but it can be applied in very other terms to lack of sleep due to many disorders. About a third of young adults report sleeping less than 7 hours on weekdays or working days. And the main predictor of this is the time of paid work and commuting time. Also, the fact that watching television is the primary activity people engage in before going to bed suggests that the extent of sleep duration may be achieved by reducing television viewing. Evaluating a patient with potential sleep deprivation should be comprehensive due to multiple contributing factors to this condition. We need to consider common sleep disorders, but also medical and psychiatric comorbidities, in addition to work, family, and socially related factors. That is why a detailed clinical history should be done first. Common tools for the subjective assessment of daytime sleepiness, such as the Epworth score or insomnia severity score, and sleep diaries are used frequently at our clinics. Polysomnography is very important not only to diagnose usual sleep-related disorders, but also to evaluate sleep architecture, fragmentation, and arousals. Two tests, the multiple sleep latency test and maintenance of wakefulness test, are done in our sleep lab to objectively measure sleepiness and alertness. In terms of acute sleep deprivation effects, the most effective tasks are long, monotonous, without feedback, externally paced, newly learned, and with memory component tasks. Patients may have also mood disorders. Microsleep and memory lapses are of concern because they can cause work and motor vehicle accident resulting in death. Importantly enough, studies have shown that certain individuals may be more resistant to the effect of sleep deprivation. With chronic sleep deprivation, the reported effects have included reduced work performance, increased work errors, reduced quality of life, increased accident, and even increase in death. Some studies have suggested an increase in mortality in patients sleeping less or equal to 6 hours and more than 9 hours. Other health problems that are increased with chronic sleep deprivation include hypertension, obesity, coronary disease, strokes, and diabetes. I will mention a test that has been done extensively in research of sleep deprivation, called Psychomotor Vigilance Test, that is abbreviated PVT. It was used in some of the slides that will follow in this presentation and will help us in understanding better the results. In short, the test requires that the subject react as fast as possible to a stimulus that is delivered at random on a computer screen. It is usually a 10-minute test. A lapse is traditionally defined as a response taking more than 500 milliseconds. Using this test, in this slide, we can see the effects on vigilant attention of 62 hours of total sleep deprivation on PVT lapses here on the y-axis over time on the x-axis. Control subjects here in blue had 10 hours of sleep opportunity every night and had a stable performance throughout the study. In contrast, the 62 hours of sleep deprived subjects had a significant impaired performance that increased with time of sleep deprivation, with only some modulation by circadian rhythm here seen as the higher lapses presenting during the morning hours. This slide illustrates an important issue. It comes from a study that shows that the effects of partial sleep deprivation on subjective sleepiness plateau after a few days, despite the worsening in vigilant attention. Here, subjects were assigned to 3 days of acute total sleep deprivation, seen in the black curve, or 14 days of sustained sleep restriction to 4 hours, here in red, 6 hours in yellow, or 8 hours in green. Two test results are shown here. The PVT on the left hand and the Stanford Sleepiness Scale on the right. This is a subjective scale for sleepiness. In the 8 hours group, seen at the bottom, lapses of attention were relatively rare and subjective sleepiness was stable and low. The 6 and 4 hours group had steady increase in errors, but plateau in subjective sleepiness. In other words, they did not feel sleepier despite the fact that performance continued getting worse with partial sleep deprivation. Moreover, the 4 hours restriction was actually equivalent to the effects of 2 or 3 days of acute total sleep deprivation. This study showed another important observation, that the effects in performance are more pronounced in the morning hours, seen here as more lapses at 8 in the morning, while the circadian drive for wakefulness provide a degree of protection in the afternoons. Other reports have suggested that the usual practice of catching up sleep on weekends may not be adequate, as may improve subjective sleepiness but not performance. Many factors are important in determining the effect of sleep loss and therefore are potential targets for neutralizing them. These include prior sleep amount and distribution, length of time awake, multiple arousing influences such as activity, light, temperature, motivation, posture, noise, drugs, as well as subject characteristics such as age and the individual's resistance to sleep deprivation. For example, the term banking sleep, with increasing sleep to 8 to 9 hours per night for several consecutive nights before sleep deprivation, has been demonstrated to mitigate neurobehavioral effects of subsequent sleep deprivation, and also reported to effectively manage fatigue, stress, and excessive daytime sleepiness, which may be useful in applied settings such as military operations and shift work. On the other hand, increased nightly sleep opportunity following a period of sleep deprivation have demonstrated different results, and inter-individual differences may account for some discrepancy in research related to recovery sleep. Finally, other typical countermeasures are increasing light, temperature, activity, and upright position that has been used with variable results. In this study, patients were randomized to 36 hours of total sleep deprivation with a previous week of 6 hours sleep restriction or a sleep extension before the deprivation. While the effect of prior sleep restriction was evident seen here in the red bar, the effect was small compared to inter-individual differences in vulnerability to sleep deprivation, seen here in the green bar. This apparently explains 67.5% of the variance. This suggested predisposition, predicting resistance to sleep, has the potential practical implications for shift worker and sustained military operation. Many of the countermeasures for sleep deprivation are included in what we call sleep hygiene, that you are most likely familiarized. There are different versions, but in general, they refer to lifestyle and environmental measures to improve overall sleep duration and quality. Other drugs and procedures that has been used are included in this slide. Of those, caffeine and modafinil are the most commonly used. Both modafinil and dextroamphetamine has been used by air crews of U.S. military services. The use for those services are beyond the scope of our clinical civilian practice. The primary source of caffeine in the military has been traditionally coffee, but the energy drinks and other high caffeinated containing products, such as workouts, are very common now. Caffeine intake in the dose range of 100 to 800 milligrams has been reported to improve cognitive functions such as vigilance, learning, mood, and memory. Caffeine and energy drinks consumption may maintain some aspect of performance in the setting of insufficient sleep in deployed personnel. In general, the current maximal recommended dose of caffeine is up to 400 milligrams a day. With this, I will conclude my presentation. But remember, that healthy sleep reverses sleepiness and maintains cognition. Thanks for your attention.